Cortisol has an effect on multiple hormones. Can you name some other axes where cortisol has an effect on?
Cortisol can have a effect on ABP, sir. It suppresses the
Okay.
ABP.
Yes.
Cortisol will suppress the TSH, sir.
Yes. Third.
And CRH and ACTH suppresses, sir.
Obviously, that's part of it. Anything else?
Growth hormone, sir.
Growth hormone. So that's very, very important to remember. So cortisol has got multiple effects. It has got a direct effect on ABP. It is going to suppress that. It has got an effect on TSH, causing TSH suppression. So somebody who has got a hypercortisolism, you will have a low TSH. Many patients with Cushing syndrome, if you look at their TSH, it will be like 0.1, 0.05, that sort of level. On the other hand, if you have an adrenal insufficiency, the TSH will be
Raised.
Will be slightly high.
Slightly raised.
So we have seen patients who come to us with primary adrenal insufficiency with mildly elevated TSH of 10 to 15. It is normal. It will improve once you correct their cortisol deficiency. And of course, cortisol will have an effect as far as the growth hormone is concerned. We know very well that if you have hypercortisolism, whether it is endogenous, exogenous, growth failure is the most common feature of Cushing syndrome of any form from that perspective. Now, very important to remember is that cortisol is affected by nutrition to a great extent. So we'll discuss about that. So what you need to understand is that entire axis is affected both in undernutrition and overnutrition. And this is important to understand because when you evaluate somebody, you need to remember. Now, before we go ahead, you can tell me what happens to growth hormones in under and overnutrition.
So, in undernutrition, IGF-1 decreases.
Okay, and growth hormone
decreases.
Growth hormone increases. So there is a growth hormone resistance. And in overnutrition, IGF-1 increases and growth hormone is low. There is a growth hormone sensitization which happens. So what do you think will happen to cortisol in obese children? Will it go up or will it go down?
It will go up.
And about undernutrition?
It will go up.
It will again go up. So DHEAs, obese, go up.
It will go up.
Undernourished, go down. So that's a different mechanism altogether. What about aldosterone?
No.
It's different entirely. So you need to understand that. We'll come back to that a bit later. So now we know that renin is basically a major regulator as far as the aldosterone production. And renin, angiotensin 2, we all know, angiotensin 1, angiotensinogen, angiotensin 2, and from there aldosterone is being produced. Now, adipocytes are very, very important and they contain a number of important enzymes. So, Dr. Alapan, what are the common enzymes, especially relevant from the adrenal cortical axis, which are present in the adipocyte? Let's say steroid, anything to do with steroid metabolism, you tell me, in the adipocyte.
Adipocyte, there are hormones, enzymes like aromatase present. There are 11 beta HSD2 present. There
11 beta HSD2.
1. So 1 present. Cortisol conversion is there.
Then
17 beta HSD is present. And another
angiotensin production, we already discussed about that. That is being produced from there. So there are multiple active enzymes which are there, and this is going to have a huge impact if somebody is obese. So now, obviously, they also produce leptin, and this leptin, of course, is a direct regulator as far as the overall steroid pathway is concerned. Now, you already told me that cortisone is activated via 11 beta HSD2 cortisol. There are other enzymes which we talk about, aromatase, which will cause increased production of estradiol. We talk about angiotensin, which is more causing hypertension, and there is more 17 beta HSD causing hyperandrogenism. So obesity is causing hypercortisolism, it is causing hyperandrogenism, it is causing hypertension, and it is causing hyperestrogenism in males. So it's like a anti-effect in both these scenarios. So let's talk about obesity there. So in obesity, basically, your fat is more, your 11 beta HSD1 is more. That's why your cortisol level will be high. And that's why obesity is a pseudo-Cushing's-like state. What are the other pseudo-Cushing's-like state? In other conditions, cortisol which are high.
Conditions in which it's stress, depression.
Yes, depression, very important. And I'm talking about those conditions where you'll think of Cushing's. Obesity, everybody thinks of Cushing's. Depression is an important feature. What else? Then other things like undernutrition, stress, illness, everybody will know that this is not Cushing. Like we had that girl who had a high cortisol and high ACTH, but we were not thinking of Cushing's in that scenario. So that becomes very, very clear. So obesity is a pseudo-Cushing state. Then the other scenario which is going to happen obviously in obesity scenario is that you've got a high cortisol. Your fatty liver deposition is more. So there your insulin resistance will happen. What will insulin resistance do to androgens and other hormones?
Androgens will increase, sir.
DHEA's production will be more.
Yes, sir.
IGF BP1 level will be less. IGF level, free IGF-1 level will be more. So insulin is going to cause problems here and it is going to induce adrenarche. So obesity is going to cause hypercortisolism. It is going to cause adrenarche. Definitely from that perspective, your ANG2 is going to be high. That is why aldosterone will cause hypertension. Which is the most important predictor of obesity in school children? Which is the most important predictor of hypertension in school children? BMI. So this is very, very important. So this is so important that if you look at it, in our study, what we found, if you are underweight, prevalence of pre-hypertension, hypertension like 4-5%. It goes to 30% in overweight and 60% when you become obese. So BMI is the major, if you talk about one factor, which can really explain most hypertension in school-going children, it is BMI. That is something which is happening probably through this mechanism, but there are many other mechanisms which are also working from that perspective. What are the other interaction of cortisol as far as blood pressure is concerned? How does cortisol affect BP?
Cortisol can, if it is in high dose, it can act on the 11 mineralocorticoid receptor.
If it is very, very high,
Very high level.
700, 800, it is going to overwhelm the 11 beta HSG2, causing hypertension, hypokalemic alkalosis. Classical causes
Classical
Cushing's ACTH dependent Cushing because of ectopic ACTH. And
AME is like
AME?
AME is at the so
and high cortisol, high ACTH scenario. But no features of Cushing syndrome.
glucocorticoid resistance.
So that is the scenario in which cortisol can act on the mineralocorticoid receptor. So this is something to remember. So cortisol is an important regulator. It also influences the epinephrine production. So if you remember, when I said there is a centripetal blood supply coming to the adrenal medulla, cortisol is high, PNMT is high, you will have increased production of epinephrine, which is also going to cause hypertension. So there are multiple factors there. We all know that illness affects the adrenal axis. And of course, if you have any form of illness, you will have increased production of CRH, ACTH, and everything will go up. So this is something well known in that regards. 12-year-old boy with obesity, height is 160, weight is 70, cortisol is 700, ACTH is high. Somebody is advised MRI. Do you agree?
No, I don't.
So
Because
why?
First, you have to.
You have hypercortisolism, high cortisol, high ACTH. So isn't it that ACTH is causing high cortisol?
No, you have to check for the first whether it is really a Cushing syndrome or not.
Okay.
Then we have to go for the etiology.
Okay.
So we need to confirm this high cortisol level by checking whether.
Yeah, 8 AM cortisol is high. So you can do a
Overnight
So you can do a dexamethasone suppression test, or you can do a scenario of urinary free cortisol. So in this case, actually, somebody thought this is ACTH dependent Cushing syndrome, did an MRI, found an adenoma, referred for surgery. The big message here is that do not get confused between the screening investigation, the diagnostic investigation, and the classification investigation as far as Cushing syndrome is concerned. What is cortisol level? Is it a screening or a confirmatory or a classificatory?
Screening.
Is it a screening?
In screening in cases of exogenous Cushing.
It is not an investigation for Cushing's. It only tells you that there is a exogenous excess.
Exposure or-
If the level are low, that is only it will tell. So screening tests are three.
Overnight dexamethasone suppression test. So library cortisol we can do, and we can go for the urinary cortisol.
Yeah, or
So
midnight
midnight,
cortisol,
cortisol can
you
be
can
done.
think about that. So clearly this case, if you should have done the overnight DEXA suppression test, it would have been suppressed. So this is pseudo Cushing's. This is not Cushing's as part of that scenario. Now, what does undernutrition do? Of course, undernutrition is like a stress state. You will have hypercortisolism, which is there. You will have other cytokines which are working. There are other scenarios. That's why your CRH, ACTH, everything will be high, and you will have a high level of cortisol. So in that scenario, probably high ACTH cortisol could be part of this axis rather than because this girl did not have any other features of Cushing syndrome, but her pigmentation weakness were the main symptoms. So most likely this is part of this axis. Yes, it will, but you need much higher level of ACTH to produce DHEAS. You need to have an older child to produce that. It will ultimately, if you have glucocorticoid resistance, which Alapan was talking about, it presents with virilization. You will have high DHEAS level in that perspective. So they will, but here the other point to remember is that there is low insulin, low leptin, so your adrenals are anyway not wanting to wake up. So bone age is low, so they will not have adrenarche in this scenario. So this is a classical example, 17-year-old girl with secondary amenorrhea for 6 months. Menarche happened at the age of 13 years, the periods were regular. She is tall, but she has recently lost a lot of weight, and the LH-FSH is undetectable, cortisol is high, TSH is low. So do you think there is a cortisol producing tumor which is causing this low level of LH-FSH and TSH? Or what is happening here?
Sir, sudden weight loss
Not sudden, over 6 month, 1 year period.
is state of malnutrition, sir, or undernutrition, which has led
Okay.
to the high cortisol level.
What are the likely cause of malnutrition in an adolescent girl who had normal periods and now has become such lean? If you see 162, weight is 34 kg.
Anorexia nervosa.
So this is a classical example of a eating disorder.
Yes.
And what you are seeing here is a cocoon response. When somebody is having an issue, they will like to go into the shell. So she has switched off her
Menses.
gonadotropin. She has switched off her thyroid because thyroid is going to waste the energy. So you will have peripheries which are cold. You will have no periods. You will have dry skin and everything, but cortisol is high. Why is cortisol high? It is basically
Maintaining the-
ensuring that she is getting some glucose out of her protein, some from her muscle. So this is the whole mechanism. What will be the growth hormone level in this case?
Growth hormone resistant state, sir. So it will be high.
Resistant, but level may be low because she's so malnourished. So IGFR will be like 0 in this scenario, and growth hormone will be plus minus. So this is a classical case of anorexia nervosa. You can also call this pseudo Cushing's, but the clinical picture is completely clear. You won't even think about Cushing's in that regards. This is a body image issue. You may need to admit and rehabilitate. What is the most common electrolyte abnormality when you treat somebody with anorexia nervosa?
Phosphate hyperphosphatemia.
Hyperphosphatemia. Why?
The sudden rehabilitation.
So phosphorus will go up. So, Alapan? No, phosphate. She's right, but phosphate high or low? What happens when you give somebody who's not eating anything, suddenly starts
Suddenly
eating?
he keeps eating, and then insulin goes up. So it will.
So insulin will
decrease
cause
the-
hypophosphatemia, and hypokalemia may also happen, but major complication is hypophosphatemia.